You have indeed given me a challenge to try and cover this topic in 15 minutes. I'll do my best to get the essentials out, but clearly it is a complicated area. So, without much further ado, when we're talking about the key factors in the function of the normal bladder, the two components, filling and voiding. So filling, when we talk about filling, we talk about continence, sensation of bladder volume, and as well as receptive relaxation, i.e. as the bladder fills, it should relax to keep a sort of constant pressure. And in voiding, which obviously only occupies a very small amount of the time in terms of the function of the bladder, so key components are voluntary initiation, and we want it to empty completely. So when we're talking about the components of the sort of micturition system, first bit to mention is the urethral sphincters. And so this is consists of two components which are then further subdivided. So the bladder neck, which really is only active during ejaculation, and the distal urethral sphincter, which consists of three components: the smooth muscle component, also known as the lysosphincter, the intrinsic striatus sphincter, which is the rhabdosphincter. That's probably the bit that we most not commonly consider to be the key components. And this is slow twitch muscle fibers. And then there's the extrinsic striatus sphincter, the pelvic floor, which we've already heard a lot about in different contexts as part of these talks. Controlling all of that is the first sort of key neurological components is Onuf's nucleus, is S2, S3, and S4. It's based in it. And you get a nerve, a somatic nerve from the anterior horn along the pudendal, and this essentially controls the sphincter and also initiates the guarding reflex to stop leakage when there is any kind of strain. There's a further connection of Onuf's nucleus with an upper motor nucleus. Actually, that the exact location of that has never really been fully identified, but we know from other studies that there must be something there that does connect. So then, having talked about sphincters, we talk about the bladder itself. The bladder is composed of multiple segments of smooth muscle, and each with their associated ganglia. Each segment exhibits spontaneous activity, micromotions. In that sense, it actually has some similarities with heart tissue, that it has its own intrinsic activity. It cannot therefore be completely denervated. It has tone and activity as intrinsic characteristics. Moving on to the next sort of important neurological component is the sacral micturition center. So in terms of this is the parasympathetic component, again from nerve roots S2, 3, and 4. This connects with the intermediolateral gray and provides the motor control to the bladder and coordinates the micromotions. In addition, the bladder has also got some C fibers, which gives reflex bladder contractions, typically in response to pain. The lumbar sympathetics are present at a slightly higher level, and these control the receptive relaxation. It's very important that as the bladder fills, the muscles relax, as we get the sympathetic storage reflex. In addition, they control the bladder neck, which we mentioned before in terms of part of the sphincter complex for ejaculation, and the sphincter itself leads to sort of relaxation of the smooth muscle. The next really important part from a neurological point of view is the pontine micturition center. So this has a medial micturition center and a lateral storage center. And this is the sort of motor center for the autonomic control of the lower urinary tract. This is where it all coordinates. This in turn communicates with the periaqueductal gray, which receives alpha delta fibers as well, which are further sensory fibers from the bladder. And this is where all the coordination occurs. And that largely are the key components. If we put all of that together, we could talk about sort of spinal reflexes occurring with reflex bladder contraction controlled by the sacral micturition center. We've got the guarding reflex from Onuf's nucleus and receptive relaxation, again due to sympathetic storage reflex. Within the midbrain, so at a slightly higher level, we've got the periaqueductal gray and the pontine micturition center. This coordinates everything that's going on and completion avoiding. And then finally, we've got the cortex, where we get the sensation of filling and we get voluntary initiation, so social voiding. So moving on from having got the sort of basics of the anatomy and physiology of this, we talk about bladder management in spinal injury. So There are some general issues for all spinal injury patients. So these include what is the level of their neurological diagnosis, and we'll talk about that a little bit in a bit more detail. But in addition, where they are in their clinical course, whether they early in the spinal injury, you get the level of spinal shock. Depending on where they are in their clinical course, things will progress and some function will return. What degree of mobility have they got? Are they paraplegic, tetraplegic? What degree of hand function? Clearly very important for intermittent self-catheterization. Degree of memory and intelligence. Has there been any brain trauma as well as part of the spinal trauma? And what level of motivation have they got in terms of carry out certain things? Social support and obviously lifestyle. The sort of management that you're going to look at in a young, active 30-year-old is going to be very different to someone who's in their late 80s and maybe less active. So broadly speaking, we've got 4 potential management options that we talk in terms of. It's voiding with control, contained incontinence, intermittent self-catheterization, and obviously an indwelling catheter. I've also put urinary diversion there in brackets because that's always a potential option, but I have to be honest, it's not one that we would take on lightly. There are situations where you might need to use that as a sort of a last resort, but generally we're talking about the other 4. So when we're talking about voiding with control, that can take, depending on the level of injury and the type of injury, it can take a number of different forms. So true voluntary voiding is likely to only occur in quite incomplete lesions. However, in many lesions, if you've got neurogenic diffuser overactivity, that allows toileting in relation to the sort of preserved bladder sensation, and you can also couple that with regular triggered micturition. So you're relying on those intrinsic contractions that occur as a result of the neurogenic diffuser activity. Emptying by straining in the face of sphincter weakness is another possibility, particularly in I've got a more flaccid bladder. Contained incontinence, so again, in terms of neurogenic diffuser overactivity, with reflex voiding, you can be voiding into a sheath or pads. Passive emptying due to severe sphincter weakness, again, that can occur into a sheath or pad. Or where there is DSD, so diffuser sphincter dyssynergia or poorly sustained contractions, that may actually limit this as an option. Intermittent self-catheterization, obviously that's a very popular form of management and clearly relies on adequate hand function, but is often a mainstay of managing spinal injury patients ever since Lapides first described this. Finally, arguably the least desirable of the different managements is the indwelling catheter. You usually would prefer to put that in suprapubically to prevent long-term damage to the urethra, and this can be used with or without a catheter valve. So we already talked about the various anatomical levels. Broadly speaking, we can just divide our management up into 2, whether this is a sort of a sacral lesion, and so conus lesion, so the conus ends at about L2 and the sacral micturition center is involved, or if it's something further up, and hence the periaqueductal gray and the pontine micturition center are disconnected. So if we start with sort of conus sacral root or peripheral injuries at that level, typically you'll get, these are lower motor neuron lesions, you get a flaccid paralysis and sensory loss, absent conus reflex as a bulbocavernosus reflex, you get detrusor areflexia or reduced compliance, and sphincter weakness or a non-relaxing urethral sphincteric obstruction. When I say non-relaxing, this then relates to the smooth muscle sphincter rather than the rhabdosphincter. So when we're talking about complete conus injuries, our options are, again, the same 4. Voiding with control, so if they're able to empty by straining, if the bladder has a good capacity and the sphincter tone is adequate, it may be possible to do that, and that gives good voiding with control. Clearly, that's not always possible, in which case you're looking more in the direction of contained incontinence, particularly if the sphincter allows that and is weak. Otherwise, intermittent self-catheterization is probably the most common form of management in this group of patients. If bladder capacity is satisfactory, the sphincter tone is adequate. Failing that, an indwelling catheter is always an option. Moving on to supraconal disease. So if you've got typically with spastic parallel quadriplegia with sensory loss, here the conus reflexes will be present because the lesion is above the conus, so that pathway is intact. you'll get neurogenic detrusor activity, detrusor sphincter dyssynergia, so DSD, essentially where the bladder is trying to squeeze against a closed sphincter. That gives very characteristic appearances on urodynamics, which I'll show you in a second, and you'll get a poorly sustained detrusor contraction. And again, that's because the bladder is trying so hard to squeeze against this closed sphincter. And again, when we look back to what we discussed in terms of the neurological side, as you can understand that because that's no longer being coordinated. So this is the sort of classic appearance of detrusor sphincter dyssynergia, where you can see the sawtooth appearance, where the detrusor muscle is desperately trying to squeeze past a closed sphincter, and you're getting this sort of up and down where it's squeezing and the sphincter is giving away a little bit, and then it's closing again, and so on, giving that sort of sawtooth pattern. So what are the options? Again, we're talking about the same 4 options, but applied slightly differently. So you can have voiding with control using a triggered reflex, typically tapping on the bladder. To be honest, this is rarely used nowadays in clinical practice because it is kind of unreliable. It can often lead to other long-term bladder problems. Contained incontinence, certainly an option using a penile sheath or pads. So as long as they've got sufficient detrusor activity and the sphincter isn't preventing voiding, this is an option. Obviously, if DSD, detrusor sphincter dyssynergia, is very problematic, and the sphincter is preventing any urine coming through, they may need to even have the sphincter resected to allow this. Alternatively, intermittent catheterization, again, probably the most important option in most of these patients. But it does require that the detrusor contractions are suppressed either with medications such as anticholinergics or with intravesical Botox injections. Otherwise, you're going to get leakage between catheterization. And then finally, as I say, the final option is always an indwelling catheter. I've talked primarily about complete injuries. Obviously, with incomplete injuries, it depends on the degree of preservation, sensation, and motor control. You may even have full control, or you may have something in between. Also depends on whether at what level the incomplete injury is at. Why do we need to do this? Why is this so important? Well, neuropathic urinary tract risks are significant. It used to be the most common cause of death among spinal injury patients until we were aware of better bladder management. So hydronephrosis in the male leads to sort of long-term renal failure, pyelonephritic scarring from infections, stone disease, and as well autonomic dysreflexia. Just a quick mention on autonomic dysreflexia, because I think it's important that every urologist is aware of that. So this is a life-threatening emergency, occurs in patients with lesions above T6. Common stimuli are sort of irritation within the bladder, or bladder overfilling, fecal loading, skin irritation. Essentially, it's a massive sympathetic discharge, and those reflexes can't be inhibited by higher senses because they've been cut off. And the signs are usually flushed skin above the injury level, increased blood pressure, hypertension, bradycardia, and headache. Management, crucial thing is to recognize it, which is why I'm emphasizing this. Remove the stimulus, empty the bladder, unblock the catheter, remove any irritants. Any urologist can come across this in any situation. Anyone's got a unblocked catheter or during urodynamics or some other form of irritation. Sit the patient up. If necessary, pharmacotherapy can be useful. So nifedipine 10 milligrams or GTN 400 micrograms sublingually available, and obviously monitor the blood pressure until things settle down. That's basically it. Whistle stop tour of neuro-urology. Thank you very much.